I'll welcome people. Unfortunately, Suzanne, our president, as I said to some people who were here earlier, her household has been dealing with the triple plague. Now her husband has the flu, and she's providing him with succor and solace and good nursing care. Uh, but otherwise, she would love to be here. And so this is our monthly program meeting. We have two great speakers who will be speaking to us about inclusion of patient populations in both medical research and care from two different perspectives. And I am so sorry, I did not pull up your bios. So, Victoria, you want to, well, Victoria has been a great member of our program committee as well as the board, and we would love to have more members of the program committee, especially folks who have really very light techno skills, because I will tell you that piece is pretty small, but it would be a great addition. And Victoria, you want to tell us a little bit more about what you do? But first I want to mention, and then we'll introduce her more fully. The second speaker is Kathy Mankepke, one of my longest and closest friends from my tour of duty at the National Institutes of Health, where she is in neuroscience at the National Institute of Child Health and Human Development. But Victoria, you want to tell us a little bit about yourself and then your presentation?
Yes, so thank you very much, Martha, and thank you very much for inviting me to speak here today. Like she said, I'm a member of the program committee. I'm also on the WAPA board, and I'm a medical anthropologist by training. I got my Master's of Applied Anthropology at the University of Maryland in 2015. I've worked for several organizations in the nonprofit and government sectors for the past 7 or 8 years. I've done most of my work in patient engagement and patient outreach in public health. That's mainly focusing on getting patients involved in the research process and helping patients learn how to use clinical quantitative research, whatever the case may be, how to use it in their own healthcare for their own good, and just how to get them interested and how to get them involved, because there's been a very big movement in patient engaged and patient-centered research. So that's where a lot of my work has been focused for the past 7 to 8 years. So I've been working with a lot of organizations that includes the Pew Research Center, Lupus Foundation of America, Cystic Fibrosis Foundation. I did my master's work with the National Cancer Institute. That's how I met Suzanne, who's our current president. And I'm currently working with the Center for Medicare and Medicaid Services on their Person and Family Engagement Network, which I'll talk about in my presentation towards the end, which is a network of patients and family caregivers and advocates who are working with Center CMS for short on their quality measures development program. So that's just what I do in a nutshell, but I'm very happy to be here. And what I want to talk to you about is sort of to give everyone a high level understanding of what CMS is doing and what they have been doing since sort of 2015 and 2016 to push what they call their person and family engagement strategy to get patients and families involved, particularly in the quality measures development area. So that's what I do.
Great, thank you. And Victoria, you want to go ahead. I think the best thing to do is if people have questions, they have a burning question that just can't wait till the end of your presentation. You can put it in the chat and I will try and catch it. Otherwise, as long as we stay on small screen, people can use the raise hand function. We'll have time after the presentations. We'll take a few questions after each presentation, and then hopefully we can have a rollicking discussion.
Okay, sounds great.
So take it away.
All right, beautiful. All right, so what I'm going to do is I'm going to go ahead and share my screen so you all can see my presentation that I put together. So I'll go ahead and do that. And like she said, feel free to post questions in the chat or raise your hand, and we'll get to those towards the end. All right, so can everybody still see that? Or can see the first slide? Okay, so I've already pretty much introduced myself. My expertise is in qualitative and patient outreach and engagement and advocacy. I also identify myself as a bit of a patient, so I'm also super passionate in that area as well. I use research in my own healthcare, so I'd like to connect with you, Kathy, as well to talk with afterwards, but we'll go ahead and we'll skip ahead. So before we get into sort of the meat of what I wanted to talk to you about today, I'm going to give a little bit of background and context to sort of where CMS sits when we talk about getting the patient from sort of subject to expert. So we're going to start by talking a little bit about healthcare services research. So CMS's current initiatives with patient partners, and when I say patient partners, this includes patient and family caregivers. This can also include patient advocates and well as clinicians to certain degrees, but usually the overall term is patient partners. And healthcare services research is an evolving multidisciplinary field that examines the accessibility and costs and quality measures. And I highlighted that because we'll be getting into that, delivery and organization and outcomes of healthcare services to produce new knowledge about the structure and processes and effects of health services for individuals and populations. And it's relevant because quality measures and quality measures development within CMS is a huge part of health services research. And then I'd also like to highlight the MACRA Act of 2015, particularly Section 101F. MACRA Act, or Medicare Access Children's Health Insurance Plan, otherwise known as CHIP, Reauthorization Act, which required that CMS solicit and accept and respond to input from stakeholders and research. And this really boosted CMS's engagement of stakeholders, particularly patients and caregivers, in its research, and then in its healthcare quality measures, and which is where we will be focusing our attention. CMS has a lot of programs because CMS is a very huge and complex organization that uses patient partners, in different areas that we could go into, but then we'd be here all night. But quality measures are unique tools that help CMS quantify or qualify healthcare processes and outcomes that can look at patient perceptions or structures or systems to provide sort of different insights into how healthcare is working under the Medicare and Medicaid services. And these help CMS look at report incidents from hospitals, patient and clinician reported outcomes, and also develop tools for outpatient and inpatient care. And this is where patient partners come in for quality measures and really make an impact on sort of like healthcare in CMS. So where are patient and partners used? So patient and partners are used in quality measures that look at hospice care, patient and clinician reported outcomes, hospital and patient safety, outpatient and inpatient care, electronic clinician quality measures, and more. For example, hospice care, you may have heard of the Care Compare tool. That was a tool that was recently released about 2 years ago. That actually came about of a measure that was developed from the input and the patient experiences that were developed using a technical expert panel of caregivers and 65 plus year aged, patients who were looking for assisted living and hospice care. And that tool was developed from their experiences as well as their feedback on a type of tool that would help them look for that type of care in their life. So what kind of necessities they were looking for, the type of care they were looking for, the type of facilities. So patients do have very much an influence on where CMS is looking for, where CMS is going in its quality measures development. And CMS really wants them to have very much a presence in the form of whether it's a technical expert panel, a patient advisory panel, a focus group or a work group, or even an interview or surveys. Sorry, I lost track of my notes. So when we look at patients as research partners, CMS did create a specific mission for what it looks for its ideology or its vision around, or mission, I should say, around patient research partners. And that is to meaningfully include patients and advocates in healthcare policy discussions and tailor care and guidance and support to accommodate the needs of patients and their families, to promote health equity and diversity in research, and reflect patient and family values and preferences in healthcare. So where this benefits CMS and where it will benefit healthcare in the future is that it helps us by identifying gaps in research points. So for example, if you have addressing systemic inaccessibility to preventive care or primary care for certain populations, it'll help us strengthen infrastructure and data systems, eliminating disparities in healthcare access and quality of care, like why is one population getting care versus another? Do we need to build a clinic in one area versus another? Enable innovation and program development, as well as reducing costs and improving efficiency. One area that always comes to mind is readmittance into emergency rooms. So certain populations often rely on emergency room care versus primary care. So why aren't they utilizing healthcare and more or less going into the emergency room more so than other populations? CMS will use quality measures development, to help us understand why this is happening. And patient partners can help us understand why this is occurring in certain populations. So patient partners influence in quality measures. So patient partners' experiences within the healthcare system and or within chronic conditions are very valuable to contractors and CMS, as they often shed light on topics that data can't otherwise capture. And that often comes in the form of sort of qualitative and ethnographic data. So things such as treatment adherence. So for example, we recently did a technical expert panel or patient advisory panel, if you will, on post-operation follow-up care for knee arthroplasty. So why weren't certain patients coming up seeking follow-up care after they had a knee or hip replacement? We had a technical expert panel of patients who had that procedure sit on a measure development panel and give us their experiences about why that was occurring. And then for another example, we had a maternal health technical expert panel for post and prenatal mortality rates for comparing African-American women versus the general population. And the ethnographic and qualitative data from their experiences, which CMS has come to refer to as expertise, helps contractors understand what measures are being used, if they are effective, and if new ones should be developed. And you can even switch out measures for healthcare in some cases. So what healthcare is being used, if it is being used, and if new ones should be developed. Now, all of this does sound good and plenty and does sound really great, but what does it look like in practice? So CMS did begin to push this person and family engagement and patient partners in its quality measures development around 2015 and 2016, and created certain tools to help its contractors sort of bring this into life, put this into their contracts, sort of things like the person and family engagement strategy and the person and family engagement toolkit to help contractors bring partners onto their projects. These were developed to sort of help standardize how CMS contractors engage patients and family caregivers under their projects and provide guidance on best practices for collaborating with them on projects. In light of that, contractors could still decide the role of the patient partners and to what degree of influence the patient partner would have on the outcome of the quality of the measure. Contractors had to create sort of a conducive space for partners to share their experiences. So depending on where the contractor was in the phase of the development of the measure, the patient partner may be more or less involved. And that could mean the patient may be brought in to just do a survey versus participating on a panel, which could have varied outcomes. Larger contractors, for example, may be more well-established and have bigger relationships with patient partners and patient organizations that they could tap into. Whereas in contrast, smaller contractors may do grassroots recruitment and have to develop their own networks for projects, which is where PFIN comes in. So for example, you might have contractors like Yale Core and PCORI, or Patient-Centered Outcomes Research Institute, which are big government contractors that have well-established relationships with patients and caregivers that can create their own groups. But you have smaller contractors that have to sort of start from scratch or do things like social media campaigns. You also have patient partners that come from diverse backgrounds and have various levels of experience of working on panels and work groups, etc. And their levels of comfort in finding their voice on a project is conditional. When I say conditional, I mean that contractors may or may not offer any kind of orientation or training on their project to help patient partners orient themselves to a project to participate fully. Sometimes contractors might reuse partners, or they might maybe only use 1 or 2 people when their contract calls for 8 or 9. And this usually has to do with the comfort level of the contractor themselves. And this more has to do with the idea of the patient partner, where CMS has put forward this ideology of patient and family engagement, patient and family equity, its health equity framework. But it's still kind of finding its footing, it's still kind of finding its voice in bringing in patients into its quality measures development. And contractors and patient partners are still trying to find ways to work together and it can be difficult to help partners find empowerment and agency to participate on. There are still gaps in how contractors engage patients fully. So how do we move forward from here? Well, CMS ultimately does understand the value in partnering with patients and caregivers for its quality measures, but is still integrating the patient partners' expertise into quality measures development processes. So some hurdles that we've still identified in our work is still building diversity while avoiding checkboxing. So CMS has recently implemented its whole health equity and health diversity framework. So CMS has pushed towards including more Black, Indigenous, people of color, as well as LGBTQ plus patient partners into its quality measures contracts. This has led to, this is a little slightly more complicated as contractors are now having to reach out to historically underrepresented, as well as historically underrepresented communities, as well as communities that are historically distrustful of the government, which calls for an additional amount of nuance where contractors now need additional support from CMS. And also, I would say, even from anthropologists. This is a great opportunity, I think, for anthropologists to sort of step in and help contractors sort of bridge that gap. As when we have patients coming in and saying that, you know, we're not necessarily comfortable coming in. You suddenly want our help and you historically not wanted us in. So for example, I have had contractors come up to me and say, we need 3 Black people for our panel. You need just 3 Black people? Yes, we need 3 Black people. But why? We just do. And when you go out to let's say the NAACP and ask them, do you know this? The patients are pretty savvy to this and will ask, but why do you need me? Do you really want to hear my story, or do you just need me because of the color of my skin? So we have to work with onboarding patients and caregivers to quality measures and health services research in a way that is fruitful for both them, but also in a way reminds contractors of sort of the experiences of the patient partners that are coming to them to sort of meet them halfway. So contractors also have to be taught sort of a level of empathy and also a sense of cultural awareness when they're reaching out to these new underrepresented communities that CMS has now mandated in some instances outright mandated that they have to include. And the last one is fair compensation for time and labor. And this one has actually been a point of contention for some contractors. All contractors are expected to give a type of honorary or other compensation to patient partners who participate on their contracts. It's not required, but it is expected. But it's become a point of contention between patient partners and contracts because patients and caregivers understand that their experience is valuable. But there is still this sort of, I want to say, I don't know if dislocation is the right word, but almost this misunderstanding of fully accepting them as partners. The way CMS advertises patient partners is almost as if they are equal to the researcher on these projects. They are an equal voice, they are an equal agent. But once they actually step onto the project, we run into almost an inequality or a disparity between their experience and their insight. So they get onto the project and you have contractors saying, well, yes, we like your voice, we like your insight, but we're just here because the contract says so. So now we are working towards, so now CMS and us, my work with my job, are working towards fair compensation for patient partners who work on these projects. So what are some of the current initiatives that I've just outlined for you? Well, now we have the CMS Person and Family Engagement Network, which is a community that CMS created back in 2019 that is now about 4 years old, of its own independently run network of patients and families and caregivers and advocates that are brought together through CMS that receive their own training, their own onboarding. They learn about quality measures. They learn about what it is to be a member and a partner. And they also receive their independent compensation, and they learn about quality measures, and they're matched to projects that match their own values, their own cultural values, spiritual values, whatever the case may be. And we act as sort of a liaison between them and the contractor. So should anything ever happen, they have somebody they can go to. And there's also the meaningful measures information sessions, which is run by another client that we work with, or another contractor, sorry, that we work with, that works directly with the other contractors, that teaches them about different ways of integrating persons onto your projects. And then also we offer additional training for patient partners and contractors as well. And then of course, there's always patient partner surveys. Whenever we try to think of ways to improve when it comes to bringing in the patient partner voice into research or into the government in any way, when it comes to changing health policy or health care, you want to hear from the consumer themselves. So we do these surveys to hear about what it is they think is most important and the ways that we can better create a space that is conducive to hearing their voice. So we host these surveys for them every 6 months. And then there's also partnering with patient organizations and advocacy groups, both through social media and also through grassroots campaigns, so that we can continue to hear from their experts as well, so that we can continue to grow this organization or what it is we're doing in our initiatives. So thank you for hearing me out. And so that is what I do. And I thank you for hearing me. If you have questions, I'm happy to answer them. Thank you for hearing me, and I welcome anything, questions or comments you have to say.
Oh, is that Kathleen, is your hand raised, or were you just applauding? Thank you.
I was applauding. Thank you, Victoria. It was very clear and helpful.
Oh, thank you.
I actually have a question. It sounds like there's almost like a sandwich. There's CMS, and there's the contractor, and then there's the patient populations that you're trying to recruit. So can you say a little bit more about the relationship of the contractor to CMS? Are these mainly are they mainly contracts, or are they sometimes receiving organic cooperative agreements, or are these all literally contracts in which the contractor has said, you go out and find us 3 Black people, 2 American Indians, and 1 poor person from Appalachia?
These are literally contracts. So the way quality measures development will work is that they will happen in 2 ways that I've seen. CMS will put out a request for proposal or some kind of announcement saying, we would like a contractor to please develop a measure around some kind of denominator or some kind of phenomenon. And contractors from different organizations will put out their bids. And in the announcement, it will say, but within that, we would like you to please include a TAP or a patient advisory panel or some kind of work group. Now, it won't say in the public announcement, like, we want you to have XYZ of this many people on it. That's up to the contractor to decide. It's when they get it's once they are awarded the contract that then they start getting into sort of like the talks of how they want it to look. It really depends on sort of what CMS is looking for and sort of what the contractor is trying to do. And depends on what CMS's current initiatives are. So for example, CMS recently released its health equity framework. So a lot of contractors are now framing their quality measures that they're developing to fit around this health equity framework that CMS just released. So that might involve them saying, okay, well, as part of our contract, we are now going to create a technical expert panel that's going to be as racially and gender diverse as possible. So that might mean that they will come to the PFA, the Patient and Family Engagement Network, and say, Victoria, we would like it to have XYZ number of Hispanic, Black, Chinese, this many people, can you please find them for us? And we would like them within 2 months. So they're trying to fit whatever CMS's new frameworks has put out.
I have another question, but I don't want to take up all the airspace. Any other questions?
Oh, Kathy?
Thank you. So this is very interesting to me. The numbers in these groups are modest, it sounds like, and so I'm wondering, has it not occurred to anybody, any of the contractors, to develop a diverse cohort of people they can go to on a regular basis to bring them into specific contract activity? I'm thinking of some of the really big recruiting firms across the country, and now they basically have a database of people and in detailed demographics.
Okey-dokey. Have a good time. If you don't talk before the holidays, have a great.
So I'm wondering if this is not something that's being taken advantage of, or is that not a random enough population?
That's a very good question. A lot of it just has to do with availability. So, you know how I said that I touched upon like historically underrepresented and also populations that are historically distrustful of the government. So my experience has been in the past, let's say 4 years that I've been working with CMS on this project, has been the people who are most eager to get involved on the quality measures development have been overwhelmingly white and overwhelmingly female. We actually do have to take some effort to actually even get men involved on the project. And when we actually have to physically go out and try to find like people of color or people from the LGBTQ community, we actually have to go through different avenues to get them. And the sentiment that I've gotten from those people that we have been able to get onto these panels has been, we didn't even know you were interested in us to begin with. And that comes from this history of them not really thinking you wanted anything to do with us to begin with, and from having to do with them just not trusting the government. It's a variety of just different factors. And also just the fact that a lot of them, for socioeconomic reasons, interestingly enough, a lot of the people that they want to be on these panels, the pattern has been that the people who are not white usually seem to be in positions socioeconomically where they can't take the time off to be on a technical expert panel, to be on a patient advisory panel, because in quality measures, these are commitments that will take several years. Maybe I won't say several years, maybe 1 to 2 years, but you're expected to be on that panel for like a 2-hour meeting, plus any pre-work or post-work, and maybe only get like $250 at the end of it. So when they think about it, they're like, well, it's not really worth the investment. So even if you go to a vendor or recruitment company, it's still a heavier lift. It's even been a heavier lift for us. Did that answer your question?
Yes, thank you. It's the white female volunteer is well known across every dimension. So as you said, there's a real challenge in getting people who don't fit into that middle class white female category.
Yeah. Kathleen?
Yeah, I just wanted to follow up with what Victoria was saying. One of the challenges, and I worked on the other side, and being an anthropologically based consulting firm, we tend to want to go to the community and find people rather than working through panels where it becomes almost professional for some people to participate in panels. The other thing is that once people become a part of this kind of effort, additional efforts create a professionalism that begins to, in my humble opinion, distort the information that you get. And so the freshness of people who are recruited from communities, the ways in which we can go to communities and find people who do actually represent the spectrum of patient partners who are needed, I think is very important. Contractors are very often pressed for production, and the government is good at negotiating the best possible price for the most possible work. So contractors also are frequently, the biggest contractors are going to be quantitatively focused and may not have an appreciation unless CMS makes it very clear that this is their expectation and that they will monitor for it, that patient partners will represent the communities and will be treated as CMS expects them to be treated. So I think there's a lot of interesting tensions in what you're dealing with. And I commend you for, the long fight. It's a worthy fight.
No, thank you. I definitely agree with everything you're saying, like seeing the value in the sort of the ethnographic and qualitative side of bringing in patients. Like you said, they're very quantitative minded, and we have run into people who are almost like professional panelists. And they often go alongside the middle class white female stereotype in research. And you often have to push for them. Like we have actually witnessed, and sometimes I've even wanted to do a study on this, of patients who actually have made entire careers of serving on panels and advisory panels and technical expert panels for the government. It's almost part of their livelihood to do so. And you bring them alongside, it takes very little effort to integrate them onto a project. And then you have to go out and you try to find fresh perspectives. And the contractor is not used to having to bring on someone who's never seen a quality measures before, who doesn't know the difference, what a risk management assessment means or a patient reported outcomes means. For example, I was working with one contractor who said, we want people who are new, who've never been on it, who are of low socioeconomic background, and we found that for them. And then they ended up not wanting them because they're like, it would be too much to bring them on to onboard them, even though we offered to onboard them. They're like, just give us the materials and we'll help them get used to it. They're like, no, it would be too much work. So they went with the career panelists instead. So I don't know Kathleen, maybe you have a better term for it than I do, but like you said, it does create a distortion.
People learn what's needed. They learn to do the dance and they learn what's expected. And that learning gets them supported, praised, attention, and it gets them on the net. I'm really not cynical. I'm just saying that there is sometimes a rush to using people who are easy, as you were saying, who are easy to integrate into the panels. But there's a cost to that easiness in some cases. So I think it's hard to find the balance of speed, production, and authenticity. And that's a CMS challenge to work with their contractors to make sure that they're understanding where CMS's priorities really are, and that CMS will monitor for those priorities to be met.
Mhm.
Yeah. Thank you, Kathleen. I do want to bring up something in the chat before we turn to Kathy, turn from Kathleen to Kathy. Andrea put a link to the CMS Health Equity CMS framework in the chat, and she also wants to know, and I don't know if you've come across this, Victoria, or not.
I have.
Okay, you see the chat, the issue of equity for, how does CMS account for equity for people in territories like Puerto Rico?
That I actually don't know the answer to. It's a very good question. So far, I've seen my experience with CMS's statements regarding health equity seems to be US based so far in our work. When we talk about the Latinx or Hispanic community with quality measures, it's usually those that are based in the United States. I have not heard mention of Puerto Rico, I'm sorry.
Oh, no, it's okay. It's a little bit of a loaded question.
I wish I could give you a better answer.
No, I ask because, I have just loved your presentation. I'm in Utah. I was a member of WAPA's board years ago when I had just graduated from my master's of medical anthropology, and now I'm my PhD in policy. And I work for the VA, and we're trying to incorporate way more community-based participatory research. And we do have panels of veterans, right? So things that you've brought up, like the career panelists and stuff like that, is critical. Well, I've just started working with VA researchers in Puerto Rico because we see these disparities that are just insane, right? And yet, because they're not a state, they're not represented when we talk about health equity or how policies are applied. So I guess that's what I'm asking, because I'm doing a special panel in Puerto Rico next year, and we're bringing VA presenters to present the fact that Medicaid and Medicare is not applied the same for territories. So that includes DC, and this is critical. I lived in DC for 4 years, right? And that's where WAPA is. DC is a territory, and the primarily Black community is not going to be served by Medicaid and Medicare the same way in DC as they are in Maryland or Virginia. And so it's just an interesting, I'm throwing it out, a little bit of a, I don't know, devil's advocate is not the word. It's more like put a buzzer in your ear, because this aspect of health equity isn't, I work for the federal government, it's not being addressed by the federal government, right? Like this, like they're doing all this work, like at the VA and other places, to say, let's bring in panels, let's bring in the community, let's listen to them. And yet the policy structure is also part of the problem. You know, so it's just something I'll put out there, is like, maybe there's a way you could try to get a representative from Puerto Rico on one of these panels and hear more about how Medicaid and Medicare are not applied.
Yeah, that would be fantastic. The issue is always just finding the people. That's always been, I think,
can help you find the people.
If you can help us find the people, you will totally hear from me.
I can help
If
you
you-
find the people. You can email me. I'll put my email in the chat. I'm part of also a caregiving network of research that we're trying to expand into like American Indian Territory and territories that like are normally overlooked. Yes, I am the white woman in the room that's helping do this, but like we've got to move it forward. You know.
Oh, I cannot tell you this, to tell you about, cracking into underrepresented. We had one contractor who requested for Native American, and I was on the phone with one of them and I was like, would you please join our TAP? And I was telling them why, and they just flat out said, I have no running water, and then hung up on us.
Oh yeah,
And
it's critical. There's critical.
and I couldn't be mad at them. And historically, and that's what I meant by historically distrustful. And like that's something that CMS has yet to address. Like I said, when they did that, I was like, I can't be mad at you.
Yeah.
Joanne? Oh, you're on mute.
Okay,
Okay, can you guys hear me? Because I'm on a tablet, which is not terrific.
oh, that's great. And this will be the last one. Then we're going to go to Kathy, and then we'll do more questions. But go ahead, Joanne.
Okay, I may have missed this because I came in a bit late. But I find myself these days doing a fair amount of work with, a for-profit marketing firm, which is doing social entrepreneur kind of things. Most of our work is for government or whatnot. And also when I was at NIH and designing something for outreach for populations like this, I heard everything that you're saying, and particularly things that Kathleen and all of you have been bringing up. But the thing that keeps coming to me is incentives. And I find that increasingly, even when I'm reviewing federal grants for to be unnamed agency that works with a population that's truly at the margins, often forgotten in your panels, Victoria. People are saying, wait a minute, giving them $100 to $200 is not enough. You got to pay these people. So have there been real conversations about incentives? Because if it's if we look at the national panels, which are again for profit, people are getting $150, $200, $300 to show up for 50 minutes, and that's it. And if you do more of these, it's more. So there's as your professional panelists, some real money here. But I'm not sure that the groups you're working with has anything like that in the budget. So what are people saying and thinking about this?
Well, I can tell you that it is like I said, it's a point of contention.
Okay.
And there's almost this is my personal thing. There's almost a tone deafness, I want to say, between contractors and CMS when it comes to hearing patients and caregivers and the type of people who are on these panels when they participate, especially those who are new, not the career panelists. So for those who participate the most, they're like, they already have like full-time jobs. They're usually upper middle class. So they're like, oh, this is fine. I can go to Macy's and do whatever. I'm generalizing, okay? But for some other people, they're like, this $100 for 6 hours of my life, even if it's spread out over the course of a few months, it's not worth my time. And you want me to do it over and over again. And they're like, well, you need to bring up the incentives. But then we're hit with an attitude from the researcher and from the government side saying like, well, you're not really doing that much. We're just asking you to give you your experience. We're just asking you some questions. It's not really work. It's not like we're asking you to give your personal information or share a personal part, and in some cases, potentially very personal information just for our research that we can benefit from. So getting them to empathize with that has been very difficult, because for them, they're not seeing it. They're just seeing the bottom line. It's like, while you're not really doing it, you're just talking. But for the patient, they're like, no, that's still the time out of my life. I'm still having to take time out of work, or I'm still having to take time out of my long day
Can you
after
come
work.
help me?
So
Right.
it can be very difficult. So it's not something it's a hurdle we haven't quite cracked, but you're right. And something that we're trying to advocate for is like higher incentives or better incentives for patients to participate. Because yes, where we are getting stuck, especially with the way the economy is going and inflation, patients are saying, no, if you want us to participate like this, especially in the long term, you need to give us more.
So thank you.
Mm-hmm.
Yeah. I'm going to ask that we move on, because sometimes people, we are going to keep this open until 9, but sometimes people are, do need to go before that. So there will be plenty of time for people, if you have a question specifically for Victoria, write it down, because we do want to hear it. But and for people who haven't asked a question, you may have something for Kathy, or you might think of something new that you hadn't thought of already after you hear Kathy's presentation. So Dr. Kathy Mankepke is a neuroscientist, and she's going to drill down. We're going to go from a more general look at inclusion to the firsthand challenges of ableism and disability, and the disparities and inequities for persons with different abilities in all aspects of life. Kathy has had a very broad and, I will say, illustrious career. She was at WashU St. Louis Medical Center. She won awards while faculty and during her time at NIH. And also at NIH, she has developed the Abilities Employee Resource Group, and has been an active member and served in leadership roles in numerous organizations that support persons with a wide range of disabilities. And she continues to create and lead innovative strategies to support persons challenged by illness-related dysfunction and or ableism, all this while having a very active program portfolio in child development. And so this is, and Kathy brings us both an insider, I don't know that I would say outsider, but insider researcher perspective. So I am going to be driving the slides, which means that I probably won't see hands. So if you have something really urgent to say, we'll let you, well, probably not a good idea to interrupt. Put it in the chat and hopefully we'll catch it, but we will have lots of time for questions and answers afterwards. Would you like me to start sharing the screen, Kathy?
Thank you, Martha.
And please, if there's anything else you want to say about yourself.
No, I think you said plenty. Thank you. I appreciate that very warm and generous introduction. Okay, so you're at the end. There we go. So next slide, please. I will say, I will just start with, I would like to do a very brief history of the concept of disability, because it relates when we get towards the end of my presentation. Essentially, as anthropologists all know already, you don't need me to say, human differences have existed since the beginning of Homo sapiens, and that we notice differences, that we have always noticed differences in visual appearance and form and function since the beginning of time. Oh, I'm sorry. By the way, Martha didn't mention that I'm, like Martha, a New Yorker, but unlike Martha, I speak quickly. So in order to get through this, I will be speaking relatively quickly, and I hope that isn't disruptive for people. So pre-modern concepts of disability focused on deviance, difference, and infirmity. By the Middle Ages, the perception of lack of productivity played a key role in the construction of disability, and questions about how to appropriate cultural resources became much more prominent. During the 4th and 15th centuries, abled as an adjective described a capable, vigorous, and thriving person or object. But interestingly, there was no opposite or antithesis to that concept. By the age of enlightenment in the 1700s, 1800s, great thinkers held out promises for the perfection of the human body, and any deviations were now identified as failures or hopelessness, and necessitated surveillance, repair, and management. And so we move in during the Enlightenment period to this concept of fixing people. By the 19th century, the shift from feudal to capitalist economies marked a change in how bodies were commodified and classified, with productive bodies distinguished from those that were considered less productive or non-normative. Bodies perceived to be unproductive or non-normative were sequestered and controlled and diagnosed and otherwise administered by a growing profession of medical professionals. So thus began the medicalization of disability. That relates to, next slide, please. The idea that of how we define today disability. So disability is a functional limitation or perceived negative difference, so that non-normative is still in the definition. Disability is wide-ranging and very heterogeneous. It may be temporary or chronic. It can be influenced by environmental barriers or supports. And for some people, it's an identity or a demographic category. That kind of represents the classic definition of the social model. What disability is not, it's not synonymous with a diagnosis. It's not synonymous with your health status. It's not a failure of the medical system. It's not homogeneous, and it's not mutually exclusive of other health concerns. And that leads us into sort of the medical model of disability is characterized by diagnostic labeling and overshadowing. Some people would say disability resides in the person. In contrast, the social model of disability emphasizes the environmental and cultural barriers of functional capacity and the emergence to accommodating technologies and civil rights laws that prohibit discrimination against persons with disabilities, and the concomitant increases in functional abilities gives credence to, and well, sorry, I've got something going on with my screen, gives credence to the functional abilities, that functional abilities reflects the social model. Also, just by virtue of the fact that the definition of disabilities keeps changing with time, again, reflects that there is a social component to how we define disability. Next slide, please. In the US, people with disabilities are the single largest and the fastest growing minority group. 26% of adults in the United States have some type of disability. Next slide, please. this is the CDC's definition of disability in terms of functional disability and the types of disability that there are, but there are many, many ways to identify disability or to label different kinds of disability, including, for example, visible and invisible disability. Often the invisible disabilities, things like heart disease or epilepsy, things that you can't tell somebody has in terms of a diagnosis, are not visually apparent at first blush. That population, people with invisible disabilities, are clearly undercounted, and often they are the most underserved because they aren't immediately brought to anybody's attention unless the person with that challenge raises the issue. The so-called targeted disabilities of the Office of Personnel Management, Federal Government Standard Form 256, has a long list of categories that meet the definition of disability, but they're quite different from what you would probably expect, including some things like significant disfigurement and dwarfism are part of the OPM definition of disability. Interestingly, the federal government uses 67 different definitions of disability, which again, just gives further credence to the social model of disability. Next slide, please. Disability is universal. Anyone at any time can experience a disabling event. Disability affects all races, ethnicities, sexes, genders, ages, socioeconomic groups, and geographic regions. Disability is intersectional, which has become a hot term, as you all, I'm sure, know recently. Disability rates are higher in adults over the age of 65, women, American Indians, and Alaskan Natives, as well as in the Black population. Disability is associated with higher rates of poverty and lower rates of academic success. Although disability is positively correlated with age, advancing age doesn't cause or precipitate disability. In the US, in 2021, less than 35% of persons with disabilities and working age adults, ages 16 to 64, were employed. Only 35% compared to the more than 72% of persons without disabilities in the same age group. These numbers are similar to those immediately pre-pandemic years because high and underemployment is found almost universally across US populations with disabilities. Disability might be thought to cause poverty, but the inverse is also true. Impoverished environments have higher rates of persons with disability. A similar complex and bidirectional relationship between disability and academic achievement exists. What is clear is that cultural biases and environmental and structural barriers inhibit both the employment and the educational advancement of persons with disabilities. Next slide, please. Next slide. So why am I talking about disability? I'll use NIH as an example. People with disabilities are underrepresented in the workforce at NIH. Remember that more than 26% of the US adult working age population has a disability, and yet the workforce at NIH has only 8% of staff reporting a disability and only 2.2% reporting one of the targeted disabilities. In the grantee population for NIH, as is true for many federal agencies, grantees represent only about 1.2% of the PI population, the investigator population. When it comes to research participants, these are the people that Victoria is talking about, underrepresented populations, persons with disabilities are underrepresented as research participants. At least we think so. We don't know for sure because NIH doesn't ask, and no other federal agency asks how many research participants or people in clinical trials or people in intervention trials, they don't ask how many have a disability unless they are studying disability. So we don't have a clue how many people participate with disability participate. What we do know is that without asking for this data, we don't know what the actual representation is, and we don't know how to target our activities. We don't know how to try and move the needle on this representation issue. What we anticipate is that currently it will be more difficult for people with disabilities of certain types to participate in research because their disabling condition isn't being targeted or for active recruitment and for appropriate accommodations. So like the panels that Victoria was talking about, if you have somebody with a disability who can't afford transportation to the location for the panel discussion, or they can't engage in communicating effectively because they're deaf and they require a sign language interpreter, or they are blind and they need assistance with engagement with printed material or visual presented material. If those accommodations aren't made up front, they're not going to participate. And if they don't see that that's going to be actively made possible, they're not going to participate. I will tell you, though, that as a person with disability myself, with multiple conditions or limitations in some way, I have been actively rejected from quite a few studies because they don't want someone like me in the research pool. Next slide, please. Studying a disabling disease, is not the same as studying disability. Most of NIH's clinical trials, clinical and preclinical basic research is focused on disease-specific level factors across a myriad of diseases. Less than 7% of NIH funding addresses disability health disparities and inequity. Again, not necessarily studying disability per se, but not even addressing inequities. And I should say that currently NIH doesn't even recognize the disabled population as a health disparities population. We currently have a request for information out to see whether or not NIH should reconsider that we don't consider disability populations as having a health disparities. The problem is that people with disabilities experience health and life events unrelated to their disabling condition, and when treated are potentially prescribed the same medications and interventions as non-disabled people with little to no data on efficacy, treatment half-life, the safety, or the appropriate dosing of any of the medications or interventions. Further, without dosing and safety guidelines, many healthcare providers may be reluctant to treat persons with disabilities. So I can tell you, when I moved to the general Bethesda, Maryland area, looking for a new primary care provider, and that provider told me that they would not take me as a patient because I was, quote unquote, too complicated. They wouldn't know what to do. These are the same concerns we've experienced in the past, at least NIH has, and many research funding organizations, federal agencies, the failure to include women because they were delicate, because they menstruated, they had hormonal cycles, they complicated the data analysis, or children who might be harmed unnecessarily, or older adults who couldn't keep up with the activity. But once we had credible data on the ways in which women's responses to interventions varied from or were similar to those as men, we were able to devise data-driven guidelines for the treatment and preventive care of women. We need to do the same kind of data-driven guidance for persons with disabilities. But this data also needs to incorporate the intersectionality of all of the things, of all of the factors, demographics that NIH already requires its investigators to include: sex, gender, race, ethnicity, and age. Next slide, please. So why are persons with disabilities excluded as research participants? Well, one of the issues is ableism. Ableism is the assumption that persons with disabilities are inferior or inadequate, leading to a discrimination or social prejudice. Ableism promotes the myth that persons with disabilities already have a poor quality of life and thus will not benefit from or engage with treatments or interventions. This is a huge problem in the area of disabilities medical treatment. Safety concerns that are not based in evidence, myths around the costs and types of accommodations needed, the heterogeneous characteristics of persons with disabilities. Investigators are concerned to make their data very messy. The medical model focuses on persons with disabilities as having an illness that is inherent to who they are, to who their what their physiology is. And does not recognize the co-occurrence of illnesses unrelated to their disability. Next slide, please. I'm going to skip this slide. I think it's pretty obvious from what I just said a moment ago, so we'll go to the next slide, please. So why count and include persons with disabilities in research? Well, it's because the federal government's mission and obligation is to support research that is representative of the US population. And when we don't represent the US population, we develop all sorts of policies and practices that inherently promote disadvantage and inequity for various populations. And we've already seen this with a lot of minority populations of any kind. So people of racial minority populations have experienced the same issue. Same thing with ethnicities. If we don't include people that represent our population, we cannot provide the appropriate services and needs to those individuals. The public health resources are tied to evidence of health needs in this country and to the disparities and inequities. And when we don't have data on populations, public health does not allocate resources to those populations. So we're back to the Middle Ages and the definition of disability in the Middle Ages, where if we don't pay attention to you, then we don't give you resources. So is that appropriate in a country like our democracy? We've had that similar kind of problem with other demographics that are not appropriately represented, and so we can't address it. Next slide, please. And I'm going to skip this next slide because it refers to, Martha, next slide, please. Because it refers to legislation that obligates the American investigator to, or the funded by federal agencies, obligation to include disability populations. I'm just going to give a real quick example of a recent example of how not having any data on the disability population had a real effect. So next slide, please. the COVID pandemic, we realized at the very beginning that we didn't know where the population of people with disabilities stood in terms of risk to COVID or to SARS-CoV-2, the actual virus. And we didn't know how to distribute vaccines that were in limited supply initially to a population that we had no idea of what their risk factors were. So what we did discover over the course of the last 2.5 years is that intellectual disability is one of the top risk factors for COVID infection. Lots of hypotheses as to why. We're not quite sure why, but we do know that now we realize that persons with intellectual disabilities are at much higher risk. People who are physically disabled are 2 to 3 times more likely to die from a COVID infection. Not knowing that, not having that data, we didn't know how to protect people in ways that would be beneficial. Obviously, we pretty quickly discovered that people who are in congregate living environments were at much higher risk. But what we didn't know was that anybody else was at much higher risk. During the course of the pandemic, we discovered that it should have been no big surprise that minority populations, persons of color, were also at much higher risk of serious outcomes from COVID. These are the kinds of data we need to have before we encounter another pandemic like the one we're just living through. Interestingly, the COVID-19 infection indirectly caused an increase in symptoms and unintended or unanticipated treatment complications. So does it matter? I think it does. Our tax dollars are going to places where we're not sure whether or not they need attention, and it's not going to the places where we think it needs to go. Next slide, please. So, a path forward. Next slide, please. How can we increase disability community participation in research? We need to build trust with the disability community. We need to increase targeted outreach to engage persons with disability. We need to fund more PIs with disability. Funding PIs that come from the community, we have found in communities of color, for example, or different ethnicities, makes a difference in, one, how they engage the community, and two, the questions they ask. And those questions usually are more helpful to the community than the traditional white male questions that come through the research community without that kind of direct experience knowledge. We need to identify and reduce barriers such as transportation and accessible testing and medical equipment, or ableist assumptions in research protocols. We need alternative consent and information forms for people with sensory and communication impairments. We need to require disability status reporting in inclusion enrollment reports. Those are the reports that people who are funded through NIH are required to identify the populations that they have included in their studies. And just recently, as of last week, the advisory council to the NIH director, working group on disability, subcommittee on people with disabilities, which I was a member of, an ex officio member of, provided a significant set of guidance to NIH in terms of what we believe are some of the changes that need to occur. So the take-home message, next slide please, is Disability issues aren't just about accessibility. They include diversity, equity, and inclusion. They are primary issues if we're going to have excellence in our research at NIH and at all of the federal agencies. We need to recognize that inclusion requires intentionality. You don't recruit people, and this is back to Victoria's comments. You can't effectively address issues if you don't intentionally include people who represent that population and who represent them from a lived experience. Federal granting agencies must work with PIs and grantee institutions to help them fulfill their federal obligations to provide equal access to research studies to people with disabilities. You know, the vast majority of clinical trials that are done in this country are done through federal funding from NIH. And if we don't, we've got to start with those institutions and those PIs to enable them to better include a representative population from the United States. Research must serve all persons in the US and elsewhere. That is the obligation of the federal government. That is written into law that we have to do that, but we haven't been doing that. We haven't been doing that with many minority populations, not just people with disabilities. So I'll end there. I do want to mention, and I should have done so from the beginning, two things. One is I am a person with multiple disabilities, and how people refer to persons with disabilities, whether it's person first or diagnosis first. There are many, many ways that people with disabilities prefer to be referred to. Phrases that are much more acceptable. I personally choose person first usually, but I don't necessarily represent, my choice doesn't necessarily represent what everybody in the disability community would choose. And so I want to be cognizant of not misrepresenting the disability community as a whole. One of my illnesses is multiple sclerosis, and a common joke with healthcare providers is, you've seen one person with MS, and well, you've seen one person with MS. We don't look anything alike. In fact, I happen to have a sibling who also has MS, one of my sisters, and our symptoms are very, very different. So that said, we are a very heterogeneous group with disability, and that should not preclude us from being active participants in research about us. So thank you. Questions?
Thank you, Kathy. That was really so thorough and so important. I want to ask people to start maybe the first three questions specific to Kathy, and then we'll open it up completely. We have 35 minutes, so Emily.
Thank you, Martha. First of all, Kathy, that was the best presentation of its kind I have ever heard. You really covered the issues that are absolutely critically important for equity and, of course, for research. So thank you very much for preparing and presenting it.
Thank you.
I have a question for you. You referred, I'm sure without any intention, mainly to persons who are, I would say, school age and above, adults. I work with the little ones from 0 to 3 or 0 to 5 or 0 to 8, depending upon the country. This is, of course, early intervention work, where we help to build national systems of it. And we do a lot of research. And a lot of research is found, you'll see it in Lancet and JAMA, various publications, neurology, etc., where there is a concerted effort to study the young child. Now, it is inadequate, of course. More should be done. But I would love to hear your comments on what you think should be done to ensure we round out the picture to include the support of families who are working with others to assist with the achieving the full potential of their children in all areas, balanced development. And again, thank you so much for your presentation.
Thank you very much. I am currently a program officer at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. So I apologize for not talking about kids. Actually, the research that I'm involved with now is in kids. I don't think, as I said, I'm a cognitive neuroscientist. So that is all about how people learn and understand and grow in knowledge, both emotional knowledge as well as academic kind of knowledge. I'm particularly focused more on science and math in the research that I'm personally engaged with, but there's no way you can address issues of, there's no reasonable way to address issues of disability in children, and I study cognitive disability, without engaging the community, without engaging the family and those people immediately around the child that you're addressing. They are gatekeepers. They are people who, at the very earliest age from birth, begin to shape how that child will see and engage with the world. So it's critical. I agree with you, absolutely critical to engage parents and the larger community, the larger social community, familial community for most children. The US is kind of unique in many, especially white populations, isolating the household to the only meaningful group of people are those people in the household, and our households tend to be one generational, two generational households. So being able to go across generations, like most of the world does, not like the US, is, I think, also really important. That transgenerational impact is significant. So thank you for bringing that up.
You're muted.
Yeah, Martha, you're muted.
Well, Joanne, please go ahead.
Okay. Again, Kathy, yes, thank you. This was amazing. Actually, I sent you a little note. I was hoping that you could go back to that slide on the legislation. And full disclosure, as a lot of people on this already know, you know, I have lifelong disabilities, plus an acquired one or two. And my uncle was a polio survivor who was part of NIH's team to find the cure to childhood cancer, leukemia, way back in the 50s. So I think you're right. The numbers are awfully low, but people don't talk about this. And I think part of it is the Maryland culture of disability, which is horrible. But one of the things that I find very ironic, and I'd like to hear your thoughts on this, is that if you look at the disability legislation, all of this is in there. And it's federal legislation. We are the civil rights group that nobody talks about. And at the moment, I'm doing the ADA self-evaluation of the college. And one of the challenges they're dealing with is that disability is not part of the DEI initiative. So having worked at NIH, having worked at HRSA, and not had much fun as a person with a disability, in both cases, I'm wondering what you suggest to make people aware of the fact that we already have these rights, that we're already supposed to be included. And And nobody knows about these laws. Nobody enforces them.
I have a very biased perspective on that, and I will freely admit that. The ADA was the last major civil rights legislation in this country. And I have to recognize that we don't have comparable civil rights that relate to sexual minority and gender minority populations. And so their time will come too. but we followed the civil rights legislation in terms of people of color in this country by decades.
Right.
Decades.
Right.
When the ADA was passed. And
so let's talk about both of them, because ADA does one thing, but IDEA does a whole lot more.
right.
That.
Right. The idea, and actually federal employees are, and anybody who receives federal funding is held under the Rehabilitation Act of 1973.
Right.
Which predated the ADA and was sort of the predecessor of the ADA. But essentially, the biggest problem is that this legislation under the ADA, but even under the Rehab Act, not under IDEA, requires that you bring a lawsuit. You file a court case to move and make somebody compliant with the law. And this is really unfortunate because in most civil rights legislation, people are brought to bear as soon as they are found out of compliance. Under the Federal Rehabilitation Act and Section 504 and Section 508, which has to do with accessibility in a variety of formats, both print, media, physical space, and so forth. In principle, that those laws should be enforced without requiring litigation. But in reality, even within the federal government, and I have sued my own agency for reasons of, like I said, I'm particularly biased on this issue, for non-compliance of a very obvious issue, reasonable accommodation. For whatever reason, society has, and the Department of Justice has chosen not to enforce by inspection, but rather by requiring litigation. This, in my opinion, is problematic. Okay. No academic institution that I know realizes that they're bound by the Federal Rehab Act. So they do not comply. IDEA, on the other hand, has been managed in large part through the Department of Education. And the Department of Education can maintain requirements, sometimes restricted because the states manage education. But essentially, the Department of Education can set standards that are required across the country, and they can enforce them proactively without requiring litigation.
Okay.
Big
Thank
difference.
You. Sure.
you.
Thank you.
So let's go to Adam and then the chat, and then we'll see if we have any more
Okay.
time.
So, hi, Kathy. It was amazing. And I guess I listened to this with a great deal of consternation about the situation with disability at NIH. And the reason is, and I have a comment and then a question. So I work for FEMA in the Office of Disability Integration. And we, without overblowing this too much, all of this makes FEMA seem really progressive.
Mhm. Yeah.
That we don't need ever any litigation. I supervise a team of disability advisors that we send to every single disaster and who make sure every single program takes disability into consideration. Every single new FEMA staff gets disability training and an additional training every single year. It's required training annually. And we have an internal office that ensures that all staff who have any sort of disability are entirely accommodated according to their needs. So having said all of that, I'm in my little FEMA bubble, and we have problems all the time. In fact, our disability office was invented after FEMA failed during Hurricane Katrina. But it learned, and FEMA figured out how badly it did post-Katrina and invented the disability office where I work. And we make mistakes all the time, but maybe this is a false sense of pride, but I feel really proud of the way that we're handling this. But so having said that, I guess the question I'm trying to get towards is the level of interagency collaboration or information exchange or sharing on programs. And FEMA is a very different organization than NIH or Department of Education, but federal government. So what are your thoughts about really increasing the level of interagency knowledge sharing and process and strategy to kind of rectify some of these things?
You won't like my answer. I'm sorry.
I might not be surprised by it, though.
There already is. There are multiple committees and trans agency initiatives. The Interagency Disability Research Committee, IDRC, sorry, which I'm on, is the group that came up with the analysis of 67 different definitions across the federal government for disability. Part of the problem with all of these groups, and I think that this interagency activity is really important and valuable, and there clearly are some agencies that are doing a better job than, I will say, NIH, HHS, parts of HHS. I think so President Biden and executive order, and I won't come up with the right number for the executive order for diversity, equity, and inclusion, and accessibility in everything federal government. So there are many things out there that are pushing all the agencies to do better. I think that one of the problems at NIH is that we are a medical profession focused agency. HHS as a whole is much more physician focused and even nursing focused. Sorry, Martha. Um, but I think that we are dedicated to the medical model, and the medical model, in my opinion, doesn't cut it, doesn't get to the reality of these structural barriers, policy barriers, institutionalized barriers. And it's going to, we're trying, like I said, we just, the advisory committee to the director of NIH just presented, and that is outside people, not people who work at NIH, just presented to the acting director, and the reception was warm and welcome. And the first question was, is where are we going to come up with the money to do all these things?
Yeah.
So
Yeah.
It's, you know, that answer is actually illegal. And I emailed the acting director and told him he just said something illegal. But because under EEOC law, it is hard to justify for any federal agency that they don't have the money for an accommodation or for accessibility and inclusion.
Right.
And it's required by law.
So just one ending, I'll take half a minute more, but you mentioned that NIH is a medical establishment, so you kind of lean towards the medical model. So it is really interesting, and you probably know this, but the 26% that you used for population was CDC's figure, but the census figure is 12.4% or 12.5%, because the census is self-reported. And people using the social model, very often they don't report themselves as having a disability because they don't feel that they do.
Right.
And that discrepancy between 12% self-reported and 26% medically calculated is massive. We use that in our training with new FEMA employees, but I'll shut up now.
I agree with you. Many people with disability do know, who have an invisible disability will never report that they have a disability. Stigma is profound.
Yeah. Andrea dropped a whole bunch of information in the chat if you're interested. And she also talks about the definition of access and the fact that the U.S. has not ratified the UN Constitution on the rights of persons with disabilities, that some other countries are more advanced. And an organization, DRI Advocacy, are you still here, Andrea? Yes. Do you have anything you want to add?
Yeah, I'm here. I really love this presentation. I love both presentations, and I think they tie in really well together because it's about that representation of voices that are normally overlooked. And but yeah, I think the policy stuff, and Kathy, you did wonders with the policy. You know, when you skipped over that slide is when I popped that in. I'm like, but wait. Because just our underlying foundation of not ratifying the UN Convention on the Rights of the Child, we have no teeth behind ADA. The only reason we have teeth behind IDA is because there's been enough lawsuits that school districts have had to pay a lot of money, and jailing services have had to pay a lot of money because of kids that are put inappropriately in institutional incarceration facilities because of their disabilities, right? So that's what actually gave the teeth for IDA. And I think it's like, I'm so excited by your talk, Kathy, and I just popped in policy stuff because that's my interest and area of, like, if we really want to eradicate some of these disparities, we have to look not just at the ground level, but also at the structural level and what we need to change in the structural level to make it work better.
Thank you. I agree.
Emily.
Yeah, I certainly agree with that point. We have very weak policy in this country, and we depend far too much on legislation. And the result is that we don't have consistency. The non-ratification of the CRPD is part of that. We also haven't ratified the CRC, which is appalling. But these are issues that do definitely need to be taken up, but we almost have to change our way of handling law and policy to be able to do that. I just wanted to ask Adam Coons whether or not he has worked with his approaches, his methods that are in FEMA at all internationally. And if so, with which groups? And specifically, has he worked with UNICEF?
So I don't want to jump in on other people's presentations, but the answer is no. I worked internationally for 30 years before joining FEMA. But FEMA does have a small international office, and I'm not connected with it at all. But we can take that discussion offline.
I was going to say, I'd love to talk to you about it because we're struggling in quite a few world regions where there is a great deal of everything from community violence to migration. That you're looking at one of the most appalling migratory movements right now in the Ukraine, going into all over Europe and really all over the world now. And I've been trying to help people to get their minds around the options for working with children with disabilities and their families. It's been extremely challenging for a lot of people to get away from certain paradigms of work and begin to think creatively. So I would love to be able to talk with you about what you are doing and learn about your activities. Excuse me for interrupting on this. I think also the presentation that Kathy gave, it would be wonderful if you would share it, because I want to go over it and really think through some of the points. You come at some issues that we deal with internationally slightly differently from the way we do it. For example, social model, we have other aspects that go under it. I just want to really think it through, and I was wondering if you would make it available.
Sure. Martha has the slides and can distribute them.
Thank you. It was just great. Thank you so much.
You're welcome.
Okay. Any other questions? Well, I want to thank our speakers profusely. I thought this was just great. And next month, return on January 11th, Kathleen Crane is going to tell us how NASA and NAPA, we hear about NASA, National Aeronautics and Space Administration, and NAPA, our Association of Practicing Anthropologists. So I'm sure that will be enlightening. And they're always looking for new programs. So I put my email in the chat. I would love for you to contact me. I would love to have more people on our program committee, but if you just have some ideas for presentations, if you want to present, or you know people who would be good presenters, let us know. And thank you so much, everybody. And I always have trouble, ending these things. So, Kathy, you want to say something about next month?
Sure. Hi. Neil Tashima and I will be talking about a fascinating project that we had with NASA. Unfortunately, NAPA will not be involved, but a band of very senior anthropologists was involved with us. It was a fascinating, anthropologically challenging, and far-reaching in terms of many things that we do project. I'm excited about Neil and I presenting to you all next month. Thank you. Thanks, Martha.
Okay, thank you so much. Good night, everybody. Sleep well. Happy holidays, of course.
Happy holidays.
Happy holidays. Thank you, everybody, for your
Bye, all.
thoughts and comments.
Thank you, guys. You're great.
Thank you both for your presentations. It was wonderful.
Thank you for having us. Thank you.
Thank you. Thank
Bye.
you, Victoria. You were wonderful. Thanks. Bye.
Oh, thank you so much. Thank you again.